Newcomb Construction is a family-owned design-build general contractor. We work using the concrete tilt-up method. We cast our own concrete wall panels on the job site, and then we tilt them up. What I really love about our job is working with the clients. They strategize and dream for their own company. We're part of it.
I'm Paul Fanlund of the Capital Times, and I'd like to welcome you to the latest edition of Cap Times Power Hour, where Wisconsin CEOs speak. Many of you know that we began this breakfast series in 2022 with the intent of bringing major CEOs from across the state to Madison to tell us about their business and also to talk about doing business in Wisconsin. I believe this is the 7th in our series, and we're very pleased with the progress. Today's speaker is Cathy Jacobson, CEO of Froedtert ThedaCare Health in Milwaukee. I've already thanked her, but Cathy, thank you again for being here today. It's wonderful to have you. Our regular moderator is Mark Richardson, who always does a great job, for those of you who have been here before. I'm not going to spend more time on their bios because you have a handout at your table. So in the interest of time, I would just point you toward that. I want to thank our sponsors and partners, without whose support this breakfast series would not be possible. Our two major sponsors are the Burrish Group at UBS and Newcomb Construction. Bergstrom Cadillac sponsors the parking, and Godfrey Kahn Law is the food sponsor for us. Our partners include Hinckley Productions, which does the video and streaming work for these events and also for Cap Times Idea Fest. Cargo Coffee provides the coffee, and I see you have a sample to take with you. So we appreciate Lindsay Lee and Cargo. And our venue host, of course, is the Edgewater, and we think this is a terrific space for this event that we've so enjoyed presenting. The only other thing I wanted to say was just to take 30 seconds and say that we very much appreciate your being here, which is supportive of the Capital Times, our 106-year-old newspaper company. We're independently owned and locally operated, and on behalf of all the rest, I'm on the board of directors. On behalf of all of us on the board of directors, we sincerely appreciate your support by your presence here today. So with that, Mark and Cathy, take it away.
Thanks, Paul. I'm over here this time, guys, in case you guys were wondering where I was. Apparently I have a bad side, and so we're going to try to avoid that today. Our guest does not have a bad side. Thank you, Cathy, for being here with us. So glad you could join us. And thank you for breaking up the boy band. Can we talk about that for a second? Our first woman CEO. Let's give it up. So for folks who don't know your story, can you tell us, a little bit about your path? What brings you here today?
Yeah, sure. So first of all, thank you for inviting me to be here today. It's a fantastic opportunity to get a chance to talk to folks over here in Madison. I have to throw out a thanks to the faces I see here from Milwaukee, for all of you who drove over here this morning, so I can see some familiar faces. Thank you. To my friends at the Wisconsin Hospital Association, who I have worked with for a very long time, and also to this young grad student sitting here in the front, my son, Kevin, who drug himself out of bed to come and see his mom this morning. So, but just thank you, everybody, for coming here today to hear my story and any kind of thoughts that are out there. So as we were talking, as we got started, I grew up in the area around Rockford, Illinois. All my entire life. So I started down there. But as anybody who might have come from that area, very, very focused on Wisconsin. So Wisconsin's always been kind of like the second home. We've had a vacation home up here for almost 23 years. So even being from Illinois, I had a lot of time in Wisconsin. Went to school at Bradley University in Peoria and got an accounting degree. In the mid-'80s, took that accounting degree and my CPA up to Chicago. I'll date myself to a Big 8 accounting firm, which we were at that time. And funny thing that when you walk into these firms, who knew, they actually give you a list of industries and want to assess your interests. So maybe you get a choice, about what kind of clients you get to work on. And, we're a bunch of 22-year-old kids, okay? We don't really know, manufacturing, consumer goods, retail, utilities. Well, one of the things that they had on there was hospitals. And that kind of takes me back home again. I did check off hospitals as one of those options because my mom was a hospital RN her entire career. So my mom worked, and she worked in our local community hospital, and we were in there all the time. You know, we were dropping stuff off for her. We went to Christmas parties. I actually worked in the hospital in the kitchen for a couple of years in high school and early college. So I was very comfortable around hospitals, so I checked them off. And then you find out accountants are not comfortable with hospitals. Nobody checked off hospitals. So we became a very small group of folks who kind of got to be experts in hospitals and healthcare finance. And it really is, from a finance perspective, number one, a little bit of a kind of niche expertise you have to get about the Byzantine way that we're paid. And healthcare, between the government and between managed care payers, were actually brand new back then. HMOs were new in the late 80s, you know, so how did you learn how to deal with that kind of payment? So you kind of got some expertise in there. But from somebody with a finance background, it's really fascinating. There's a lot of different things that you touch on. You issue bonds in the municipal bond market. You build very large buildings and construction projects. You do leases. You have vast investment portfolios because, believe it or not, we're required to keep double the amount of our debt on our balance sheets. So you have to be able to have all of those investments and be able to manage it. So it really was a fascinating type of career to get into. And like many kids that go up to work in these big accounting firms, I had absolutely no aspirations at all to be a partner in an accounting firm. My aspiration was to get hired by one of my clients, and maybe someday I get to be a controller, you know, the top accounting person. That was my career aspiration at the time. Sure enough, got hired by my largest client, by an organization today known as Rush University Medical Center in Chicago. And at the time, they actually, in the late 80s, owned the second largest managed care company in Chicago. So they had gotten into the business in the 70s, had built this up around their employees, but it actually had hundreds of thousands of lives. Back in the late 80s, they were I audited the whole thing, so I actually started at the insurance company, at the HMO. And I spent 8 years there, became a CFO at the age of 27. But I always would say that that was more because no one else really wanted the job, and I was working harder than anybody else, and the CEO noticed me. So I got to do that. So spent 8 years there, actually ended up being in charge and running, you know, probably just about any operation in the insurance world except for sales and clinical management. But 4 CEOs in 8 years, it was a troubled organization. And I said, you know, time for a change. I had just gotten married. I had had my oldest child, and went to the folks who were on our board at the main medical center, at the main corporate, and told them, you know, I'm going to make a change. You know, it's time for me to make a change. And they said, nah, not so fast. Why don't you come over here and work for us? So I started working for the CEO of Rush University Medical Center and the 3 C-suite executives who were really working there. So I went from having hundreds of people reporting to me to kind of more in a staff role, but working pretty at the highest levels there. Got to do a lot of fascinating things for the first 6 years there. Sold the health plan, actually, which was fantastic for Rush because they needed the money, which I'll talk about in a minute. Built a compliance program, not my favorite job, but I did it, you know, so I know compliance pretty well, inside, outside, and backwards. But probably most importantly, started working on a financial turnaround. Medicare actually made the single biggest cut to the program they ever made in 1996, and it disproportionately hit academic medical centers. Rush saw it coming, put a lot of people on it in terms of like, how are we going to adjust and everything, and failed miserably at the execution of it. Mm-hmm. And got into an enormous amount of financial difficulty at the time, to the point that people were throwing out words like zone of insolvency, which is basically functional bankruptcy, you know, at that point in time. So the board decides to make a change in the CEO. They go to do a search. It was a very public failed search, which made it into the newspapers. This is getting to be really scary times in Chicago, and appointed the internal candidate, which was one of those people I was working with, the head doctor. His name was Dr. Larry Goodman. And very quickly after that, asked me to step into the CFO role because the CFO had also given notice that he was leaving because it wasn't a real fun time to be a CFO. So I did it, and I took the job. Now, by this time, I was working part-time. I had 3 children who were 5, 3, and 1, and decided to step full-time back into what was not going to be an easy sliding job here. So I did go back to work. I did negotiate to stay at home 1 day a week on Fridays so that I could, kind of manage the little kids, every once in a while, or at least see them every once in a while. But did that, basically for the next 6 years. So we were able to turn it around by about 2006, started to come out of that, started to generate, some additional money where we actually could start to invest in the business again. And at that time, I got the opportunity to run strategic planning, marketing and communications. Let's put the finance person, in charge of marketing and communications. They taught me a ton. You let experts do what they do best, and they will teach you a ton about what you're going to be able to do. And during that time, now I got to work with these wonderful physicians and nurses and clinicians and people about how were we going to invest and grow. So all these relationships that I built about how we could kind of bring our resources together to stay alive, now we could invest and grow. And that's when I think the financial, intellectual part of healthcare that I loved turned into a passion for healthcare, because you really recognize that your job was to create resources for these wonderful physicians and clinicians and nurses to do what they do best, which is take care of patients. This was a really special place. They are renowned for quality in Chicago. They are the quality leader. They're one of the national quality leaders in the country, and we had to save this place. And so it really came about to then create a passion, for healthcare. So obviously that went well. Did some national work in my association. You get to be known for that. And in 2010, Froedtert called. And I had looked at a couple of different opportunities. And I think what was different about the Froedtert opportunity, which made it work, let's face it, you can see from my background, I've worked for 3 employers in almost 40 years. I don't move around a lot, and so I like to stay in a place. I am very, very attached to my extended family, my immediate family, my extended family. They're all around the Rockford area. Milwaukee's an easy move. And especially for a kid coming out of the Rockford area where you have played in Wisconsin your entire life, going to Milwaukee was not a hard move. And as I always say to my friends in Milwaukee who kind of maybe have a chip on their shoulder for not, being Chicago, everybody in Chicago really thinks you're a cool, funky city, okay? Yeah. It's really cool, to be in Milwaukee. So it was an easy move up there. Froedtert had a lot of the things that I think that healthcare of the future needed. It wasn't just an academic medical center. And boy, when they took me up to the campus, I'm like, best kept jewel, in the Midwest. I mean, it's bigger than anything in Chicago except for Northwestern today. Wasn't at the time, but the campus is extremely impressive. The Medical College of Wisconsin faculty are extremely impressive. And knowing the business, from which I come from and everything. And they had started to branch out. So we had community hospitals, and we had physician practices off campus, and we had primary care, and that was very, very different than what we had in Chicago. So I thought they had all the pieces to fly, and we did. So that's how I got to Milwaukee.
Wow. It's funny, your job became your passion versus the inverse, right? Which they'll tell kids today, follow your passion, right? Your job ended up being a passion. You've been in one industry the whole run, which is great and pretty unique. So what's been the biggest change in healthcare? And we'll get into the business model because that's crazy. We had an earlier speaker talk about nuclear fusion. That might be easier to talk about than the healthcare business model. I don't know. You break it down for us.
Yeah, exactly. So I think the biggest change that I've actually witnessed over time is, and again, maybe it's just from my position, is that we have access to data now in a completely different way than we did. And I would go back even to my health plan days about what we were trying to do to manage, utilization and care. We weren't managing utilization and care. We didn't have the data to do it. All we could do was see dollars and how we aggregated them by where we were spending. But we couldn't tell what was going on with the patients. We didn't have electronic medical records. We had to abstract everything off of paper, back then. So you really didn't know what was going on in healthcare. So I think the biggest single change that I've seen is data, but then more importantly, the application of that data, and what we can do with it in a completely different way. So we can go from back in those days, how did we measure quality? For example, like in the late 80s, we would do paper chart abstractions. You would have nurses sitting with paper charts and analyzing the outcomes or what might have happened with a medical error or an infection or something like that, and they'd do like 20 charts and extrapolate it, okay? We didn't know what we were doing. We absolutely know down to the patient level today, what is going on with that patient in terms of what we think the diagnosis is, what their treatments is, how they're reacting to their treatment, what their outcomes are. How can we track the things that shouldn't happen in healthcare? We couldn't do that in the 80s and 90s. Now we know every infection. We look at every single death and how did it happen and why did it happen. We look at drug-to-drug interaction, which is almost should be mostly eliminated when you're on an electronic health record. So it's just a vastly different way to manage the business, and those are just a couple of examples. Then we can go into precision medicine and predictive analytics and artificial intelligence. All of that was enabled because of the fact that we got digitized. And we didn't really get digitized until the 90s. And so when you see where healthcare is today, it's because we were operating on paper until about the early 90s. And think about getting all of that data now. Now we're just learning, really, are on the cusp of figuring out what to do with it. So I think that that's probably the biggest change. But out of that then comes all the changes in what you do, with it. So quality is a whole different game now. In terms of measuring quality, focusing on what you need to improve. How do you actually coordinate care and communicate with your patients? Completely different business now, than it was, 20, 30 years ago.
Yeah.
So that's the biggest transformation I've seen.
Yeah, I wouldn't have guessed you would have said that, with sort of robotics and all different technology, but really it's the data.
Yeah.
Cool. During our call, you said something that struck me. You said, the economics of the healthcare industry don't make sense. And I thought, well, I don't even know where to begin to ask. I don't know enough about it to ask the right question. So tell us what you mean when you say the economics don't make sense.
Yeah, so I've described it as a Byzantine Jenga game, okay? Any of you play, Jenga, the big tall thing, and you start pulling stuff out, and it collapses, okay? So if anybody asks you why hospitals closed in the Chippewa Valley, it was a Jenga game, okay? And people started pulling all the stuff out that made money, and all the stuff that didn't make money stayed in that hospital, and the thing collapsed. So I would say on a global basis, this is how to think about it, because it is Byzantine, and it's really, I could get into weeds in a very deep way on this stuff, but at a global level, okay? There's three basic areas of the four, really, that pay for healthcare in the United States. Federal government through Medicare, state government through Medicaid, employers, and patients. The smallest piece of that is patients, by far. Single biggest is government. So if you think you don't have government-run healthcare in America, yes, you do. Because it's primarily driven by the Medicare program, which gets bigger every day because this country is aging at an enormous pace. This state is aging at a really fast pace. And so the faster it ages, the bigger the Medicare program gets. And by the way, the commercial insurers aren't terribly innovative on their payment models. They copy mostly what Medicare does. So what Medicare does pretty much sets kind of how, we get paid throughout the United States. So that's number one. Number two, unlike the pharmaceutical industry, who now is getting to be able to negotiate with Medicare for the first time, we don't negotiate with Medicare, and we don't negotiate with Medicaid. We might have some influence through our associations. Thank you, Wisconsin Hospital Association, for representing us at the state. But individual hospitals do not negotiate anything, with the federal government and the state government. They pretty much tell you, what they're gonna do. When you're with managed care payers, you have long-term contracts. So our contracts are at minimum a year long, a lot of times 3 to 5 years long, because everybody wants, both them and us, want predictability, in terms of our healthcare prices. So we try and lock those up into longer-term contracts. And then again, consumers are paying the out-of-pocket piece, and paying a piece of their employer premium also as well. So this is the problem. The government has never kept up with the rate of inflation, never. I mean, so if inflation's 3%, 2%, they're giving us like 1%, increases. They might publish it's 3 and then they take a whole bunch of it back through other changes that they make. Medicaid, until very, very recently, never gave increases, so it was flat, okay? Well, the cost of healthcare goes up, right? We have to pay wages. That's 60% of our cost is wages. I'm not even gonna touch on pharmaceuticals. My lead person managing that every day is sitting here. That's a massive expense for us in terms of pharmaceutical pricing, supplies, and all these kind of things. It's kind of manageable in a low inflationary rate because we could always take cost out enough to kind of cover that gap in between. But there's two factors going on right now. Medicare is growing at a very accelerated rate because of aging. So now all of a sudden we were managing 50%, high 40% of governmental between Medicare and Medicaid. We're now at 60%. And you lose money on it because, again, they're never covering the full cost. So you're losing money on 60% of your business, and it's growing, and you have to try and make all your margin out of the rest of it, which are consumers and employers. So that's the game that we've been playing for the last decade. It has gotten out of whack because Medicare is growing very, very fast, and inflation hit the cost. So when I'm paying 8% increases in nursing salaries compounded year over year for 3 years in a row, and other salaries are going up, and pharmaceuticals and supplies have gone up at a much faster rate, and you're getting 3, 2.5 from Medicare, that gap's just too big anymore.
That's unsustainable.
Yeah, it's unsustainable. So, and that's why the system is starting to break. That's why you're starting to see hospitals close. That's why you're seeing financial distress and, quite frankly, some of our other very large health systems in the state. And it's come late to Wisconsin because I think we're organized better for healthcare here in Wisconsin. You have a lot more integrated delivery systems. You have a lot of diversification in the insurance market. We have a lot of provider-based health plans here and so on. So this wave has come later to Wisconsin than it has come to others, but the system's starting to break. And then you get into the intricacies of we make maybe a little bit of money on surgery, we lose a lot of money on medicine, and when all your surgical cases are pulled out, like that happened up in Eau Claire, the Jenga game starts, and then you start to see a collapse.
Yeah.
So that's a very high level, hopefully simplified version
Yeah.
Of what we have to manage.
Yeah, that's compression, right? And you're in the middle, and here it is. So is that the primary driver for the decision to merge? Or how did that come to be?
Actually, it wasn't. So what you're seeing, I'll say in a big picture, maybe yes, but not specifically to Froedtert and ThedaCare. So you're seeing a lot of consolidation in the healthcare industry right now here in Wisconsin. Also as well. We in Milwaukee have 2 very large national systems now, headquartered outside of Wisconsin. Ascension's headquartered in St. Louis, and Advocate. Atrium is headquartered in Charlotte, North Carolina now, actually not even in Chicago. So there is a lot of consolidation going on in the system, in the industry. There has been in Wisconsin, also as well. What I would tell you, and I'm going to quote one of my board members, all of these consolidations or partnerships, I would say, even if maybe you're partnering with a large service company. ProHealth in Waukesha just did a very large arrangement with a group called Optum, which provides services to the healthcare industry, owned by United Healthcare, largest employer of physicians. Also want to just throw that in. So different kinds of partnerships are going on. All of these, I think, are what she called, and I've quoted her often, a strategic thesis on how we're trying to figure out how to navigate going forward. So I think actually people don't understand what we're actually going to do navigating forward. And so what we're trying to do is figure out, how we're going to actually get there. There is something to be said that maybe, you can scale your back office or something like that. If you consolidate, you can. I mean, I will tell you, when you bring in single hospitals into a health system, we did that when we brought in our hospital up in Manitowoc. We lowered their corporate expense when we did that, because it was cheaper to do that on a bigger base than it was in a small hospital up in Manitowoc, Wisconsin. But the bigger consolidations haven't necessarily proved that yet. So the question is when is big too big and diminishing, but people are still trying it. For us at Froedtert ThedaCare, it was really a different proposition. So Froedtert and ThedaCare are actually financially almost exactly the same in terms of how we operate. It was just Froedtert $3.5 billion, ThedaCare $1 billion, so we were just bigger, but operating margin was the same, balance sheet ratios were the same. We were both making money. We both returned to operating margins that are positive, but not at a level that allow us to really reinvest in the business at the level that we want to. But what we were seeing is really that because there is consolidation going on in the market, talent is starting to migrate to the bigger systems. Mm-hmm. Partnerships are starting to migrate to the bigger systems. So we've actually punched above our weight, I think, at Froedtert. ThedaCare has also as well, on attracting tech partners, innovation partners from across the country because we're able to do things with them. And that's what they want. They want partners who actually can help them implement. And we've been able to do that, but now that consolidation is happening, they don't want to run around to 5 separate systems in Wisconsin. They want to go look for 1 or 2. And we figured out we needed to be one of those 1 or 2. We needed to be bigger. So Froedtert had recognized that. We had started to make some moves outside of southeast Wisconsin. We have a hospital in Manitowoc. We have a partnership in Kenosha. ThedaCare noticed that. And Dr. Andrabi and I actually think the same a lot about how healthcare got to where it is, where we think it needs to be in the future, how to fix it, and how to get there. And so the alignment was pretty quick on what we were trying to achieve. So sure, will we look for value savings? Of course we have to, because it costs money to do the transaction. Right. And yes, there will be value savings, but it wasn't the first thing that we did together.
No, so it was as much a proactive move as it was a reactive move.
Very much. We think we were getting ahead of the game as opposed to reacting in a time of distress.
Okay. So the merger, it's complete, right? Did it take effect?
Took place January 1st.
January 1, okay. And you're staying on through?
80 more days.
80 more days. Not that you're counting.
Not that I'm counting.
Not that you're counting or anything.
Yeah, exactly. One of my aunts gave me a retirement clock countdown, so that's why I know that. But June 30th, yeah.
Okay, all right. Well, and we'll get back to what you might do after those on the 82nd day or 80. Well, imagine a nap on the 81st day. So
not setting an alarm.
There you go. We'll talk about where you're going to go. But as far as patients and the operation, how will it change now that the merger is done and you're starting to operate together?
The most exciting thing, of course, you do the business stuff first. You've got to talk about your IT systems and your revenue cycle and, all of that kind of stuff. And there are a ton of opportunities in that area. But what makes me really excited is that we have turned our physicians loose on figuring out our clinical strategy. And so, how do we take the best of both worlds of these 2 systems? ThedaCare operates obviously up in the Fox Valley, Appleton, Neenah, but has 5 critical access hospitals, which we've never touched, in the Froedtert world. They do quite well with them in terms of getting into the community. So you have rural healthcare, community-based healthcare. You come down to Milwaukee, you have suburban, urban, and we are pretty deep in the city in Milwaukee. So you've got everything from urban to rural and everything in between. We have the amazing capability of the Medical College of Wisconsin and specialty work that is best among the country, being done there. How can we do better at making sure that a patient in Shawano can get to the highest level of care they need and get back home and get taken care of in Shawano and not have to spend 6 months down in Milwaukee or something like that? So that's what we really envision for the future, is that how do we build this system that has literally every level of care that you need, pretty much ever, and make sure that patients can find us and get to the right places at the right time. And now being geographically, located on the eastern side of the state where the populations are and everything, we're serving, we have access to well over half the population of the state. Okay. And so really, how do we make sure that we're bringing that into our communities? It's work that both of us have been doing for some time, and then creating value, out of that, which we at Froedtert call right care, right time, right place, which is the highest level of quality, at the right place, which means the lowest cost, at where you can actually deliver that care to the best outcome of the patient. And again, because they're so similar in terms of how we view healthcare, we think the solutions are the same. How do you deploy technology in a different way? ThedaCare has an innovation initiative. We have an innovation company. How do we bring that together, to really, maximize our value? So a ton of opportunities going forward.
Cool. So all is not lost, even though the business model is a little jinky.
It's jinky, but, I think the thing I got to say about healthcare in our industry, we do move slowly in healthcare. We really do. And it does sometimes take, financial exigency to get yourself in gear, kind of thing. So, and the other one, obviously, it would have been very sad if we didn't learn anything out of the pandemic. We actually took a ton of lessons out of the pandemic. When your hospitals are full, you're trying really, really hard to keep people out of your hospital. We always have been trying to keep people out of our hospital, but you get extremely serious about it when your hospitals are full. Our hospitals are still full. So how do you use those lessons to really emphasize right care, right time, right place? They don't always need to be in a hospital.
No, appreciate that. And you guys, as you're sitting at the table, I can see you thinking, oh, I got a question. We'll have a mic. We'll move it around, pretty soon, and you guys can ask a question from the seat. As the industry business model challenge we talked about, what are aside from the model and kind of who gets paid and how you get paid, what are the other major challenges facing the industry?
Sure. I'd say the next biggest one's workforce, without question. And everybody post-pandemic was dealing with we still are, with workforce shortages, and we are across the state. I mean, I meet with a group of Milwaukee CEOs probably about every 6 months or so. Manufacturing, hospitality. I mean, everybody has a workforce shortage. And again, we talk about it actually at a Milwaukee level, we talk about it at a state level. As I always like to describe Wisconsin is we're a best kept gem, but when people come here and move here, they stay here and they age in place. So we don't have a lot of people moving into Wisconsin. We have very low growth in Wisconsin, population growth in Wisconsin, but boy, everybody loves it and is staying and isn't aging in place. And by the way, you need more healthcare as you age. So we're really in a pinch in terms of not bringing in enough people into the state to do the jobs that we need to do the jobs, and our demand is insatiable and off the charts right now in terms of what's happening because of multiple factors, but one of which being aging in the state. So I would say workforce is the next, and we invest significantly in terms of our own dollars, in terms of putting program into schools, into colleges and scholarships. We have, believe it or not, for years, one of the worst professions to try and hire for was surgical techs, and that's pre-pandemic. We are putting $600,000 in to pay people a salary and be trained to be a surgical tech, and I'm going to get 12 people out of that investment. 12.
I was going to ask what you were doing.
I employ, I think, roughly 40, 60 if we're full surgical techs. We have a lot of surgical techs. I'm going to get 12.
Wow.
So, and we have a number of those different initiatives, that are going on. Nurses, obviously, a huge investment. It's our biggest single workforce. So workforce. Now, what that forces us to do, though, is we in healthcare tend to just throw people at stuff. And we haven't been great at adopting technology. Okay. That whole thing, we have not maximized the use of technology. And technology continues, digital connections, AI, still exploring, kind of playing around with what that's going to do for us. We have to learn how to apply technology in a real way that we eliminate the need for people. And I like to say we're not eliminating jobs. We never eliminate jobs. We might say we don't need you over here, but by God, I got about double the number over here where I need you. We might ask you to move around, but we never let people go. Now people may choose not to do that, but we are at a size and scale now that we also can do that and move people around, to where we need to do it. But we have to learn how to leverage technology better in a different way. So I would say workforce. And then the cost challenges, particularly, I would say pharmaceuticals are off the charts, right now. Supply disruption, again, you just have to manage that. That's a manageable thing in terms of what we're trying to do. And patient expectations are completely different now, and we have to adjust to that. Why shouldn't, and we can do this now, so I can say this, but it took us forever to be able to do this. You used to get a text message from like your dentist or your hairdresser, right? To confirm your appointment. Do you know how hard that was for us to figure that out? It shouldn't have been that hard, okay? But now we can do that, types of things. So, the expectations, scheduling online. Have any of you tried to do that? It's actually not that easy to get an appointment scheduling online. We got to make that easier.
You would think it would be.
You would think it would be.
There's other things that are harder, like surgical tests.
It is, but believe it or not, surgeons like to control their schedules, not always to the convenience of patients. Okay,
true.
so you have to deal with your physicians and their schedules and all those different types of things. So we have to get better at serving our patients in our communities a different way.
Okay.
Yeah.
Yeah, you see my eyes rolling back in my head because I'm thinking about the challenges that are in front of us, and you're right, workforce across the industries. But it would seem it requires us to do something that we're not really great at, and that's changing at some pace.
Without question, yeah.
Not that AI is going to take over jobs,
No.
but it's going to take jobs that allow you to have humans over here.
That's right.
Right?
That's exactly how we look at it.
So we have to be less scared of that.
That's right.
We'll talk about Inception Health because I think
Yeah, we're learning a lot about change management.
Yeah.
A lot.
Yeah.
And about how and why technology hasn't taken off in healthcare. If you talk to a physician, they're not going to stand up and clap for the Epic system. I'm going to tell you that, okay? They don't like it. They don't like using it, okay? It's gotten better. Epic is very good at listening to their users. They have gotten better, but it is still seen as a burden to our physicians. So we are doing something wrong in technology if it's not helping our physicians, but it's causing them more stress in their job, and it's been shown for the last decade it absolutely is. So we instead of trying always to change the physicians, we probably need to start changing the technology a little bit and meet in the middle, somewhere. The other thing that I didn't mention as a challenge is demand. We are overwhelmed. The system, meaning not just Froedtert ThedaCare, is overwhelmed with demand right now, whether it's aging, deferred care from the pandemic disparities, definitely in urban Milwaukee, definitely drives some of our demand. The mental health pandemic that is going on, we have insatiable demand for the healthcare system right now, and we are overwhelmed. And that is the other part that's kind of breaking the system. You don't have enough workforce. You're trying to pay people extra shifts, get them to come in, all at extra times, and the patients just keep coming.
So sheer volume.
Sheer volume is insatiable and over the top right now.
Okay. So, in your mind, it's funny because as you have 80 days left, on your way out, what do you think are the fixes? Where are the fixes to the system? Or if you had a magic wand and you could make a few things happen, what would those things be?
We have to get upstream. We have to stop the incoming. So I've talked a lot about how we manage it, as we go through this, and we have to do all that to manage the technology and the workforce and all those kind of things. If the system, per se, is going to get fixed, we have to get way, way upstream and stop the incoming. So yes, disparities are real. They are absolutely real. We have the data, that we can study, we can look at it, and we have to challenge ourselves on how we can do better. How do we make sure that women get screened for mammograms even if they're in an urban, underserved area? How do we make sure people get screened for colonoscopies even if they're in an urban area? And by the way, it doesn't matter where you are. No one likes a colonoscopy. So how did you do better, on that? How do you use Cologuard? How do you use other types of things to do that? So we spend a lot more time now than we did, say, 10 years ago on trying to address those types of things. How do we, and we do, again, we have data. We know exactly the things that should be and are recommended for all of our patients to stay well. Whether you're a 50-year-old in the suburbs, you're a 50-year-old in urban Milwaukee, or a 50-year-old out on a farm, up in rural Wisconsin, we know exactly what you should be doing and what you should be doing to keep yourself well. And we, as a healthcare system, need to start, kind of badgering you a little bit to get in and make sure you take care of yourself. And if you can't, how do we help you do that? So that's number one on the healthcare system. Number two, some of the biggest drivers that we have are social determinants of health. Do you have access to decent food? Do you have access to housing? Do you have access to healthcare because you're working a job that's 12 hours a day? And by the way, we schedule only during the day, for the most part, for you to see your doctor. How can you get in to see your doctor? How can you get that test? How can you find transportation to be able to get to that facility to do that test? So those are the types of things that we have software that helps us identify food insecurity. Here are some community resources we can send you to. Housing, here are some community resources we can send you to. So, but we need more than just, that's what we're doing as a healthcare system. We need more of that from the community to address the incoming. Mental health, what can I say?
Yeah.
It's been underpaid and under-reimbursed, so no one does it. So it is very underserved, and it always has been in my entire career. It always has been. But now we're really meeting what is literally like a pandemic. And people are starting to call it that, the mental health pandemic going on. And it's been proven mental health can drive your physical health. Physical health can drive your mental health. We have to stop separating the two and really start to integrate that better.
Right on. So at the top, I mentioned you're our first woman CEO, and we talked about diversity in our prep call and how important it is to you. And can you share why it's a core value of yours and it has been for some time, and I'm sure Froedtert ThedaCare it'll continue to be?
Yeah, I think, so when I started my career in the mid-'80s, and I was young, as I got promoted, like I said, 27 years CFO, and you start sitting in C-suites, I was the only woman in the room all the time, and at first you kind of notice it a little bit, and then quite frankly, it kind of became ubiquitous to me. I never even questioned it anymore. And it really, and I'd say two things really kind of woke me up to that. I was in a finance committee when I was in Rush, and I had 4 directors from finance who had come to those 2 women and 2 men. And the 2 women walked into my office after the meeting, and they said, "Did you notice that only we got asked about our kids and our families and how we balance our families?" She goes, "They have families too, the guys do." And so it's just kind of like these hits in the face, that, you get so inured to it, that you don't notice it and you're like, this isn't working. Okay, so that was one. And number 2 was probably a couple meetings, and again, this was earlier in my career, so I'll have to blame it on Chicago. But, but where literally you're the only woman in the room, and there are no people of color, none in the room, so, and people are talking about how we're gonna build a program for women, and they're literally telling me how to do that. That was amazing. So they're, giving their opinions on how to do that, or how we're gonna go into the schools in urban Chicago, like they knew what they'd ever been in a school, in urban Chicago. So it started.
But they were gonna build a program that was.
But was gonna build a program,
fix everything.
To fix something in urban Chicago. So what really comes across when you sit in these rooms is that, wow, we could use different voices at the table. And it really struck me through my own experiences that you really have to have other voices at the table. So I think that's where my reckoning came from. And I think the industry at large has started to wake up to the fact that we need to reflect the communities we serve. People, it does impact your healthcare. If people don't feel comfortable in their environment, they can't communicate in their environment, you don't understand what background that they're bringing, cultural background in many, many ways, impacts the way people perceive healthcare, they perceive a hospital, they perceive a doctor. And so we need to have the voices of everybody at the table if we're going to meet our goals of having the highest quality, the highest patient experience, and our strategies going forward. And so we have to reflect the communities we serve, and we have to reflect them at all levels where their voices can be heard and where their voices can actually impact us and impact what we do and impact our strategies. I think what has been our secret sauce at Froedtert specifically, and we'll continue as we become Froedtert ThedaCare, is when I came to Froedtert, there was already a diversity and inclusion officer. So Froedtert was already on that journey in 2010. But there was a diversity plan That was kind of written up as a side manual. And as we started going through some of our first strategic planning, it became very, very apparent that it wasn't just a good thing to do, to really help urban Milwaukee or whatever. It was essential for our business and strategic success to weave diversity throughout our entire strategy. How do you achieve top decile quality if you're leaving behind, because of disparities, a huge chunk of your patients? How are you serving your community if those patients don't have access to you? How are you going to show up in experience, which again, we shoot to be one of the best in experience, if you don't have people telling you how they're experiencing you a different way? So I think our secret sauce is that we have weaved it into all of our strategic priorities, whether it's quality, experience, growth, our workforce, everywhere along the line. And then it becomes your business. Not just a nice thing to do, but an essential thing to do. And we measure it and we put investment into it and continue on with that. The work is never done. There's a lot of work to do in that area, and it won't work unless you're being very, very deliberate about it. That's the other thing that I've learned over time is just saying you're doing something. I really got after our team on disparities because I kept seeing data and data and data. And the readmissions are really bad in this area. And what are we doing? Yeah. That's different, about that. And really telling people, and we're much more creative now about, well, that didn't work, will this work? Well, we try and do this and talk to our community about what works.
So it's not a compliance thing, it's a competitive thing.
Absolutely, absolutely. And I do believe that we're able to attract workforce in a different way because of the environment that we create. And that and it's shown. I mean, we actually have become, I'm pretty sure, I can quote this accurately, that we are seeing, are a market leader in terms of people of color seeking us out, in the Milwaukee area for care. That we have grown immensely. And again, that's part of our growth goal. We measure that.
That's awesome. That's awesome. I've got a zillion more questions, but we're gonna open it up to the floor, and we're gonna let you guys ask some questions before we get out of time, because I ran over last time, I think. Shame on me. But we've got about 14 minutes left for those of us that are counting. 80 days and 14 minutes left. Questions for Cathy. There's a microphone. Who's got the mic? Oh, I see Dr. Anthony right here.
Where people use the ER as primary care. How are you managing that?
Yeah, how are we managing that? So we are right now, us and Aurora are really the two big emergency rooms. Unfortunately, Ascension's Hospital in the city has struggled a little bit with being able to do that. So I would say the single biggest thing in Milwaukee that helps us with that, and this was, again, created before I got there, is a group called the Milwaukee Healthcare Partnership. So believe it or not, these highly competitive healthcare systems sit around a table on a regular basis, and we have created a number of programs to deal exactly with what you're saying with the uninsured and the underinsured, because often Medicaid patients also don't have access, to healthcare. And again, the barriers of transportation, the barriers of how do you get to your doctor's appointment, all these different types of things. So there's a number of programs that we've built up, specialty access for the uninsured. That's actually administered primarily out of Froedtert, because we are the big specialty hub, to make sure that people who are uninsured and underinsured can get to specialty care so they're not bouncing in and out of your emergency room. There's a program specifically to take emergency room patients and put them back in a medical home in their neighborhood, which could be one of the systems, could be a federally qualified health center. We work very, very closely with the federally qualified health centers in Milwaukee to try and get the uninsured connected with them because they have different access to resources for the uninsured to take care of them, to be able to do that. So it's never-ending work, but those are some of the things that we've done. We have put in, we do have a clinic in the center of the city. That's a relatively new, we have one on the northwest side. We have now one on the south side, a residency clinic. So we've done it directly ourselves. We do it through partnerships with FQHCs. We do it through the Milwaukee Healthcare Partnership. But again, it takes a village to be able to do that. I would tell you the thing I'm most proud of, there's a lot of things I'm proud of in the Milwaukee Healthcare Partnership and the things we've done, but mental health crisis. Milwaukee County has pulled back on providing mental health in Milwaukee County, particularly their crisis center, which are where people in crisis have to go. Where do the police take somebody when they picked up somebody with a mental health crisis? They used to go to the behavioral health center. They said they were going to stop doing that, which would have had all of these people flood our emergency rooms. And those are, number one, that's a very bad place for that patient to be. Number two, it's a really bad thing to bring a patient like that into our emergency rooms. As busy as they are, we paid. The three healthcare systems in Milwaukee came together and put money into the Milwaukee Emergency Crisis Center. And Advocate Aurora runs it on behalf of all of us. But we came together collectively to do that, to make sure that those people could be taken care of.
Good question. I see one behind you.
So, a nice talk, Cathy. We met briefly. And even the hospital systems want to keep people out of the hospital. That means prevention. And yet we do very, very little for prevention. That's investment in people or companies who are trying to make tools for prevention, reimbursements for example, a nutritionist to talk to a patient to get them to know what to eat, physical activity, physical therapists. So how can we break that barrier to improve the health of people before they come into the medical system?
So we do a lot of that. So now I will plug Inception Health a little bit. Our innovation company, Inception Health, has really helped us develop a lot of the different tools so that you can do those outreaches in a different way. So out of Inception, which is kind of our incubator, we built a virtual care team out there who does reach out to our patients to help close gaps and all of those different types of data, to be able to identify those gaps. We do pay for nutritionists. I would say some of the barriers on the prevention, probably the biggest one, and I am a finance person, so I kind of lean back on this, but people do what gets paid for, okay? Is that the reason that we're doing a lot of that stuff now is because we as providers are taking financial risk. So we are taking financial risk. Number one, we own a health plan, okay? So we want to keep people healthy so we can keep their medical costs down. But we actually are at risk for the cost of healthcare of probably hundreds of thousands. I think we're up over 500,000 patients that we're managing in some kind of risk type of format. Then it starts to make sense, to invest in these types of things. As an employer, I have to tell you, and as somebody who owns an insurance company, a big part of the barrier, and I think this is the barrier on why a lot of this doesn't go forward and doesn't get invested in, is how long are you keeping those people on your risk? So if your average employee turnaround, say, is 5 years, and you've spent a lot of money in terms of keeping them well, maybe you're paying for their GLP drugs these days, and that's going to reduce their weight and reduce their risk of diabetes and heart disease in the future, and they leave you after you've paid for all of that. That's a big piece of why employers don't pay for it and why insurance companies are hesitant. Insurance companies, they lose people basically on an annual basis whenever anybody annually re-enrolls. So there's still financial barriers in the system as to the why, on why people don't invest in that. And I think until we can pull those resources more holistically together, you're gonna see gaps in terms of how fast that moves. Again, we are community-based, we're a not-for-profit healthcare system, but I will tell you, we barely break even, and I'm not kidding, in terms of how much money we bring in, not just in the health plan, but on these risk arrangements and the amount of money we put in to managing care and gaps and preventative medicine is barely break even, on that. And we're doing it more as a community investment than anything else.
Do you have another question back there?
Hey, good morning. I just came back. I spent the week at the Becker's Conference in Chicago, and there were lots of themes and phrases consistent throughout the conference, but one was hospital at home and leveraging technology. There were comments made that physicians need not worry about losing their job, but physicians who don't embrace technology should, by those who do. And so I'm just curious. So I saw the article this week that ThedaCare started using the Moxie robots, and there's other digital appointment scheduling and these sorts of things. So how is your organization leveraging the physician to champion embracing that technology for those who aren't?
Yeah, I think that's a great question. Number one, my chief digital officer is a physician. So I think that that's number one. I think you have to have physicians lead the change for physicians. So what we did and what we recognized is, because we were gapping, in terms of adoption on some of the, there's a way you do it on the electronic medical record. Epic actually is really good at teaching you how to do that. And we have a SCAD of people, who manage Epic and the electronic health record. But as you bring in these new things like digital connections and digital tools and now AI and everything, you need to apply a whole different level of change management. And so we did create a transformation office. Also as well, co-led by a physician, one of my high executives and one of our physicians also as well. And she would literally go in and sit with a primary care office and walk, why did our application of this mental health app that we prescribe to mental health patients, why aren't you guys using it in here? Well, we moved the button in the EHR and they couldn't find it. Are you kidding? So it's like finding out these micro things, that matter. Clicks to physicians, we measure that stuff, and everything. So I would challenge, I don't think we're letting any physician go, whether they use their technology or not. I don't think that's ever gonna happen. What we try and do though is make sure that the technology is working for them. And it's gotta be able to extend and support the physician, and it can't be an extra burden. Because if it's an extra burden and it's optional, like some of the digital stuff is, they just won't do it. And so how do we actually help them? That's a huge lesson learned. I think that we've learned over the last 20 years, that we've been working with implementing electronic systems and electronic health records is, number one, we burdened our physicians, and number two, we can make this better. And we need to make it better.
Great. And we're getting close to time. So one more. Do I see a hand half raised? No? We're good? We're good? Okay. So one personal question. We've talked a lot about the industry. We talked a lot about, Froedtert and ThedaCare. What about you? You say retirement, but I'm getting the feeling you're not really going to retire. So what's going to happen after you're going in there every day and after the nap? Then what? You've got something planned.
Yeah, I'm fortunate. I do serve on a number of boards, and I have 3 that are going to continue: public board, private board, charitable board. But I think they also reflect where your passion is. So 2 of those are healthcare boards. My public board is ThedaCare Health, applying technology to healthcare, which is really one of my passions, because I think that's how healthcare is going to change. And it's the only way our system's going to get out of this. My private company is a healthcare services company, and I also joined the board of a charitable organization in Milwaukee when I was invited to, which is very focused on continuing to support urban Milwaukee. Education, people in need, getting to the things that are social determinants of health. So I'll stay very involved in urban Milwaukee also as well. I was at a women's leadership panel, and I described when you're in these jobs, when we're in these CEO jobs, you're in a very, very public role. We are also very much funded by the government. And so you got to kind of watch. You're not allowed to really show your passions and fly your flag, let's put it that way, because it can lash back on your organization. You represent your organization. So I have some other passions that I might not have been able to let fly. You'll find out about them in 80 plus days.
Nice.
And I'm starting to think about that. So, where do you apply your passion? So no, I'm not retiring. Overall, I'm retiring from running health systems. You'll never see me run another health system again. How could I? I've got a job that has been a gift to my life. I get to leave it in a way that is such a gift. I can't do any better than that. So go apply myself, to other roles. Spend more time with my family to the extent that, my children will let me be around them. I'm extraordinarily blessed. My parents are in their mid-80s, and they're still alive around the Rockford area. So they're close by, and travel. That's what you're going to see me doing.
Good, love it. Can you guys help me thank Cathy Jacobson for being here today?